Well, good afternoon, everyone. My name is Donna Emanuel, and I am the director of the DNP program here at Western University of Health Sciences in Pomona. It is with great pleasure that I will be introducing Elizabeth Morrell, who is going to be presenting to all of us here today her DNP scholarly project. I look forward to this with an wonderful open heart for all of her tremendous hard work that she has accomplished throughout her scholarly journey with us here at Western U. We are very fortunate to have here with us today many of her mentors and invited guests who are on the call this afternoon. Very good. And thank you. If all of you could mute your phones, that would be greatly appreciated. And so it's with great anticipation, Liz, that I know that you've come to this wonderful end of your journey here at Western U. I could not be more proud of you. And your scholarly work speaks volumes in terms of practice improvement change at your institution and through the work of your strong guidance and mentorship by so many. With that, I would like to take this wonderful opportunity to introduce Dr. Jan Bowler, who has been working alongside of Elizabeth as her faculty mentor and advisee throughout this journey, as well as many others on the call this afternoon. With that, I'd like to thank each and every one of you for supporting Elizabeth during her doctoral scholarly journey with Western U. And without further ado, Jan, I'd like to introduce you so that you can further the conversation along.
Thank you, Dr. Emanuel, and welcome everyone. I have been very pleased to have had the honor to serve as Elizabeth Morrell's faculty DNP project chair. What is so exciting to me about working with Doctor of Nursing Practice students is to witness firsthand their leadership in, it's really the leadership in the triple aim of better care, better health, and lower cost for care. And in addition, the fourth aim of better work experience for those who provide care. Liz has done an exemplary job with her project. She came into the program as a seasoned nurse leader, and she was like a sponge that was soaking up whatever she was learning throughout this program. And she also works in a setting where high performance is a standard in the culture. So it's kind of a wonderful petri dish for her to do her brilliant work. So Liz, it's been a pleasure working with you, and now I'll hand it over to you.
Good afternoon, everyone. Dr. Bowler, thank you for your kind words. I'm privileged to present my DNP project today. My project is entitled Peripherally Inserted Central Catheters, which is a PICC, and the efficacy of tip placement confirmation with ECG-ultrasound guided technology and chest radiography. I would like to first acknowledge the following individuals for their ongoing support and guidance. And there are several individuals in the room and they're online today or on the call. Dr. Jan Bowler, my chair and advisor. I appreciate your positive, creative mind and ongoing support. Dr. Rodney Hicks, I'm grateful for you taking the time to edit and review this project in order for me to finish. Dr. Donna Emanuel, for your enthusiasm and dedication to evidence-based outcome research. Deb McQuillan, you're on the call, I believe, my mentor, community member, and my nursing colleague for your true leadership and one who embraces change in healthcare. Dr. Donna Agan, statistician who makes stats understandable. You're an amazing professor. Gabe, thank you for your guiding me through what is needed to complete my project. And to Scripps Health in particular, Scripps Mercy Hospital in Hillcrest, San Diego, for allowing me to perform this study in the facility. Lastly, to my colleagues, family, and friends, for your unending gratitude and so much love and support, and to my amazing family, my husband, John, and my two sons, Ryan and Nicholas, along with very close friends, thank you for your support. In this presentation, I will present to you the work I've done during the last 3 years. But before I begin, I would like to explain the purpose and the aims of this project. The purpose of this project was to evaluate the efficacy of PICC tip placement confirmation using a fully integrated magnetic tracking system and ECG-ultrasound guided insertion technology, which was performed at the patient's bedside by venous access nurses and validated by the post-insertion chest radiography report. I'll use chest X-ray in short. The practice was appraised in settings where PICCs were placed utilizing ECG ultrasound technology to potentially improve patient care, quality patient care. There were 3 aims, a lot of pre-work for aim 1, which I'm going to go into more detail on that. This was needed to change before I could answer aim number 2. So the first aim was to increase the number of inpatient PICC insertions by the venous access nurses. Aim number 2 was confirm the proper PICC tip location by venous access nurses, compared that to the chest radiography report. And then aim number 3 was to examine the labor costs associated with the PICC insertion in both interventional radiology and venous access nurses using ECG ultrasound technology. I will go through the specific aims in more detail after I review the background and framework. To better understand the project, I would like to define a few terms. The PICC definition is an indwelling central catheter that's inserted into the veins through the upper extremity of the arm. The catheter tip's placed in the superior or inferior vena cava, preferably the cavo-atrial junction, just as superior to the right atrium. Since a PICC is a central line, it can be an access point for germs to enter the body, causing deadly blood infections. Therefore, it's important to insert it correctly and always keep it clean. The implementation of appropriate PICC insertion techniques and utilizing evidence-based practice guidelines for PICC maintenance can help reduce the risk of central line-associated bloodstream infections. PICCs are indicated for the administration of fluids, blood, medications, and frequent blood draws. ECG ultrasound technology is another definition, such as the Sherlock 3CG with tip confirmation system, has a magnetic tip on it that tracks the proper tip placement. The portable ultrasound machine system provides immediate confirmation of catheter placement or a misplaced PICC. This is used in patients who have a P wave on their ECG. You can see that on the right-hand side there, the type of the device on the site right there. Annually, 2.5 PICC procedures are performed in acute care facilities and infusion centers in the United States. Evidence supported the electrocardiogram method as a valid alternative to radiological verification of central venous catheter tip placement. The Infusion Nurse Society in 2016 guidelines do endorse the American standard for proper PICC placement in adults is the third lower or distal of the SVC or the cavo-atrial junction. Our current process for post-insertion, post-PICC insertion requires a stat X-ray. The theoretical framework used for the pre-work of this study was Lewin's theory of change, 1951. The 3 stages focus on unfreezing, changing or movement, and refreezing. The framework is simple and easy to understand for planned change. Unfreezing involves evaluating the forces and moving individuals or groups to change. This is the most stressful and most difficult stage. Changing or movement is when individuals develop perspective of the change. Clear communication should occur during this planning and implementation phase. Share with the staff the benefits of the group of the change and how change will affect the group, answering questions openly. Refreeze is a critical time for constant attention and involving the clinical nurses and leadership. Lewin's change model was applied to the PICC project to implement change from the IR staff who were inserting the PICCs in interventional radiology to the venous access nurses carefully who were going to insert the PICCs at the patient's bedside. The dimensions were carefully assessed with a clear plan to unfreeze the system, provide movement, and then refreeze to normative states. The tools used during the change project included strengths, weaknesses, opportunities, and threats analysis, a timeline, communication plan, and process mapping, and an interprofessional collaborator tool, which is called the ICAR tool. I'd like to note that a baseline ICAR assessment was done in October of 2015 with the venous access nurses, and the reassessment was completed in August. I did another one, August 2017. And there were 6 dimensions that they rated. With the reassessment, the results had increased from the developing stages in most of them to competent and mastery stages, rating 3 and a 4 in all 6 dimensions. So the reassessment results provided affirmation to the group and leadership that all venous access nurses had expanded their knowledge of their new role. As you can see on the right, there's a process flow mapping that was completed to understand the current state of the project. Both the venous access and IR steps were mapped for the PICC insertion. As you can see, there's several steps. There were 7 steps for the PICC, the venous access nurse to insert from the beginning to the end. And then for the IR under Morrell, there's a little bit few more, there's 9 steps. So there's a few more steps that's done. In the transition phase, the aim, what we were to do was to look at the number of PICCs that were done in IR and the venous access nurses over a period of FY 2014 to FY 2017. As you can see, the transition from IR staff is there in red and began in January 2015. The green was the interventional radiology staff who are inserting the lines that are blue, and then we moved to the red for the venous access nurses. The monthly data of this was shared with the executive team, the radiology department, and the venous access nurses so they could see where they were progressing. Just to note, in 2015, the volume for PICCs were 702 that were inserted in either of the departments. So prior to the venous access nurses performing the insertion, they had to complete a 3-hour online PICC course, an full 8-hour day of PICC didactic with this new device, and 6 hours of hands-on training with the company's clinical nurse specialist. And the CNS observed them inserting 5 bedside PICCs with the ultrasound software. Prior to independently inserting the bedside PICCs, each venous access nurse was critiqued by the CNS on technical competency and clinical proficiency using the PICC competency checklist and the clinical observation tool. By February 2015, and after 3 months of PICC training insertion, each venous access nurse was competent to place bedside PICCs. The venous access nurses' expectations were to A, insert the bedside PICCs using ECG, ultrasound guided technology, and B, be an expert in access management. I'd like to note that during this refreezing stage, a new peripheral venous device, which was called a midline, was released in October there of 2015. And that's a midline's a little about 8 inches long. It's a distal tip dwelling into the vein outside the heart. And the venous access nurses also needed to be trained on insertion of the midline catheter as well. So the nurses followed appropriate indication criteria, resulting in a decrease to 470 PICCs that were inserted, which was a 33% decrease. But what happened was there was an increase in midlines that I don't show you on here in 2016, and that went up 50%. And right now we're inserting almost 120 midlines versus the PICC. So things are kind of changing as we speak. By 2015, the hospital had a full access, venous access led team comprised of 4 full-time nurses, and they were trained on the Bard Rate 8 ultrasound machine. Patients were confirmed with a P-wave and if they were candidates, and then they used the integrated Sherlock tip confirmation system. Once the appropriate placement was completed, confirmed, a printed copy of the tip location with the ECG tracing was placed on the patient's chart. A post-insertion chest x-ray was performed to confirm tip location. The PICC and midline process was completed in 2016, and they were able to recommend appropriate line placement to clinicians with the system-wide IV therapy tool, a patient assessment, and the patient's clinical condition. These nurses gained more confidence in the role and line selection, built trust with physicians, and increased their collaboration among all clinicians caring for the PICC patients. As I said, AIM 1 was a big one, and it needed to be completed before I can ask AIM 2, which is to evaluate the efficacy of my particular project and looking at the insertion. A structured review of the literature was conducted and appraised utilizing the Johns Hopkins evidence-based practice rate scales tool about the practice of PICC insertion placement with ECG ultrasound guided technology. And a review of the literature was conducted. 34 articles were applicable to the study. The themes I looked at was related to the PICCs using evidence-based practice tools, guidelines for PICC practice throughout the nation. Research studies that looked at PICC technology, PICC ultrasound guided imaging, catheter tip location, tip placement technology, insertions, malpositions, PICC post-insertion outcomes, and PICC training and PICC cost analysis with bedside insertions. This project was a retrospective quality improvement project. It did receive approval through the system IRB and the imaging care line as well, and then Western U authorization. The type of research has been conducted in other hospitals throughout the United States. However, in order to change practice with the study's healthcare system, the protocol needed to be replicated, analyzed, and accepted as a prototype study in one of the system's hospitals. The study reviewed health records of 125 adult patients who had bedside placements using the PICC placements using the SiteRite 8 ultrasound system with the integrated Sherlock 3CG TCS technology. The study took place in one hospital in Southern California within a larger health care system. The data collection included electronic medical chart review of the PICC insertion documentation note and the patient's post-insertion chest report. A stratified random selection of patients meeting inclusion and exclusion criteria was examined. As you can see, the inclusion criteria were adults over 18 years old. They needed to meet the criteria for a PICC, and they had to have a P wave on their ECG. The exclusion was anyone less than 18 years old, and we did not insert anyone that had AFib, AFlutter, or a lack of a distinctive P wave on their electrocardiogram was not included. So what I looked at was I de-identified the patients, and then I randomly selected from the large group that was given to me, 125 patients of patients who had PICCs that were inserted by the venous access nurses. Time frame was July of 2016 to June 2017. The findings revealed gender of the subjects were not equal. Of the 125 patients selected, 88 or 70.4% males had PICCs inserted compared to 37 females or 29.6%. The uneven distribution between males and females was concerning to me. So a more detailed review of the full PICC data set that I received revealed similar results in gender distribution with 331 65.8% males and 172 34.2% females with the PICCs inserted at the facility during the selected time frame. So the imbalance of more males than females was unpredicted for this study. The primary indications for a PICC were antibiotics, total parenteral nutrition, chemotherapy, and multiple medications. As you can see, the majority of patients needed antibiotics. This is a Pareto chart that was based on the primary diagnosis of the PICC patients. The highest was infection with cancer and sepsis being secondary. The common groupings were in alignment with PICC insertions and the need to have central access for these patients. Other data points I looked at was PICC lumen size, the French size, catheter size, arm selection, and vein selection. As you can see from there, the single lumen and dual lumen were pretty close together, and triple lumen catheters that we were using, they were the sicker ones that were in the ICUs, but primarily we used more single lumen size catheters. The French size was either a 4 French or a 5 French, and it was 50% in both of those categories. As well as the arm selection, right versus left. As you can see, 80.2% of the arms, the PICCs were inserted in the right arm versus the left. The reason for that is that it's easier to go in on the right side because it goes right into the heart. The left side's a little bit more challenging because you got to come across, and so you just can see that's the first kind of they usually start on the right side unless something happens and they need to switch. The veins used was the basilic most of the time, 64.8%, and the brachial was 32%, with just a few of the cephalics, 3.2%. Lastly, this figure illustrates the number of insertions by each venous access nurse. 5 nurses performed PICC insertions during the study. The nurses were de-identified and coded as nurse A through E. 3 of the 5 nurses inserted more than 32 PICCs. 1 venous access nurse inserted only 1 PICC during the study. The remaining nurse worked part-time and performed 18 insertions. Nurse A had the most insertions and had no complications or repositions. The notes from the radiologists were interpreted the post-insertion chest x-ray. They were analyzed. All radiologists were de-identified for the study. In all, 14 radiologists read 128 x-rays. 3 patients needed their PICCs repositioned, and the same 3 patients had additional x-ray for tip confirmation. These 3 additional post-insertion chest x-rays were not read by the initial reading radiologist who identified the malposition, but by 3 different radiologists. So this represents a consistent reading process for all 14 radiologists. The figure shows the turnaround time was calculated in minutes from the time the chest x-ray was completed to the time the x-ray results were in the computer. The elapsed time ranged from 7 minutes to 183 minutes, with the mean time of 59.116 minutes. So what will happen is that if there's a significant findings as a malposition or a misposition, the reading radiologist will notify the venous access nurse in order to manipulate, write an order and manipulate the PICC. And then the venous access nurse will follow out the order. A second chest x-ray is ordered after the PICC has been repositioned. So based on the post-insertion x-ray, only 3 PICCs insertions were needed to be slightly pulled back or repositioned. As you can see, there were 7.6% of the time was a successful insertion in a correct position the first time. Those PICCs that were in too far, they were just into the right atrium and you have to pull it back a few centimeters, which I'll show about. So there were 0 complications during the insertions of all 125 PICCs. The venous access nurses, as you can see, one venous access nurse C, inserted 2 of the 3 PICCs, and venous access nurse D inserted 1 of the PICCs that required repositioning. The 3 repositions were all female patients, and the tip was located in the right atrium of the heart every time on the x-ray. As you can, when I drilled down further, I looked at the what type of lumen did they have. All 3 of them had dual lumens, and they all had a 5 French size catheter. They were all in the right arm. and then 2 of them had was in the basilic vein, and 1 was in the brachial. The height and weight of the 3 patients were analyzed, and interesting that all female subjects were 5'4" or less and weighed less than 145.2 pounds. All 3 patients had 1 additional X-ray, adding the cost to the procedure. The chest X-ray after repositioning in all 3 patients revealed the PICC tip was in the proper location per the radiologist's chest X-ray report. Again, there were no further documented complications in any of the 125 PICCs inserted at the bedside using ECG technology. Based on the PICCs, when I looked at the PICC and how far they needed to be pulled back to be in proper position, there was one that had to be pulled back 2 centimeters, and then 2 of them had to be pulled back 3 centimeters, which is a little over an inch. So based on this methodology, an ample sample size of the population for the study was achieved. The third and final aim was part of the quality improvement study was to assess the labor cost of the PICCs inserted in 2 different groups and associated with the PICC insertion with the venous access nurses and the IR nurses. I wanted to see if there was a significant cost difference with that. So labor cost and time needed for staff to insert the PICCs were examined in each group. This table depicts the average time the venous access nurse took to insert the bedside PICC with ECG-ultrasound guided technology. For example, the 60 minutes there included a consent, a chart review, patient education, patient prep, procedure, and documentation. And the radiology tech was to perform the chest X-ray was 15 minutes. The total labor cost for the venous access nurses and radiology tech was $67.47, and the total procedure time was 75 minutes with 7 process steps. So based on the results of the study, if the post X-ray was eliminated, the labor cost and time would be limited to the venous access nurse time, which was, as you can see, $57.53, while it cost, and the time was 60 minutes. And it would decrease the process steps to 4 with no fluoroscopy exposure during bedside PICC insertions. So the average time for the IR staff to insert a PICC under fluoro is detailed in the same way that I explained as the venous access nurses did in terms of documentation, etc. The total time for the IR and the IR tech and diagnostic tech and transporter time was 110 minutes with the total cost for labor of $81.17. This includes 9 steps for the IR staff. The process would not change if no process steps would be eliminated since the 3CG tip placement is not performed in the IR department. Patients who do not have an existing P-way or ECG continue to have PICCs inserted in the IR department. There is no overall overtime accrued in either group, as PICCs are not considered emergent or urgent and need careful assessment for appropriateness prior to insertion. There was a labor difference of $13.70 per insertion if performed by the venous access nurses versus the IR nurse team. If the post X-ray was eliminated, there would be an additional savings of $9.94, totaling $23.64 difference per insertion between the venous access nurses and the IR team. This is an opportunity of cost savings in labor time and should be carefully evaluated. The cost of supplies are important to evaluate for PICCs. However, the supplies used for the PICC insertions are the same for both groups. For this study, the actual supply costs were not itemized since the PICC kits are standard throughout the system at this time. The implications for practice is that the results of the study serves as a prototype to adopt this practice throughout the entire health system. The number of steps to insert a PICC in IR, as I told you, was 9 steps. The venous access nurse had 7 steps. However, if you eliminated the chest X-ray, they would drop to 4-step. The advantages of this is that the patient for the venous access and doing it at the bedside, they would not have to leave the room and they would not have any radiation. The reflections are related to the AACN essentials. I would have to say they're applicable to myself and to nurse administrators, and the importance of understanding the AACN essentials and routinely overlapping these essentials into practice. You evaluate the clinical practice in the healthcare delivery system to improve the quality, the patient safety, and influence those healthcare outcomes, as well as expand interprofessional collaboration with administration and physician leaders, leadership groups to drive and evaluate effective use of supplies and propose cost-saving initiatives. And then lastly, but probably most important, is to provide safe, patient-centered, timely, and cost-effective care for all individuals and all populations. This kind of goes in with the triple aim that we continue to work on in evidence-based practice through the IHI. In conclusion, I'd like to just close with the following about this PICC project. I would say the venous access teams inserting PICCs at the patient bedside is a cost-effective approach in the inpatient setting. It was noted that first-time PICC insertions, 125 patients had a success rate of 97.6% with 0 complications. For patients who have a P wave on ECG and are in stable condition, I would recommend that all bedside PICC insertions be with the Sherlock 3CG TCS, and consider eliminate the post-insertion chest X-ray. Cost difference, I will note, that is between IR is $81.17 and the venous access nurses of $67.14. That is $13.70 difference per insertion. And utilizing PICC best practice protocols, advancing PICC technology with proper maintenance of lines and a dedicated nursing team can improve patient safety and the patient experience, which would result in a reduction of cost to the patient and to the hospital. This concludes my DNP project. I have references attached, but I found this an amazing journey in my nursing career, and I'm honored to be part of this Western University DNP program, and I am open for questions.
If anybody has any questions, go ahead and feel free to unmute yourself and ask the question.
Oh, thank you for telling me we could. I was missing the mute. Liz, this is Jan, and thank you so much for this this detailed presentation. Well done. I'll have one question and then I'll open it up to everybody else. For some reason, I kept getting hung up on the finding about the discrepancy in gender, and back on slide 11. And I wondered, there's a lot of questions that came to mind, and just wondered, is this representative of demographics with these diagnoses, or do you have any speculation about the distinctions?
Well, I did look at, I was concerned about that as well, but then when I looked at the bigger group, and I had seen and read that a lot more males have more infections, whether that they get a PICC or not, I don't know. There has been other studies that I saw that some of the studies were equal, where it was 50-50 male, female, but then in other studies I'd see this kind of similar to what I saw. So whereas more males than females in those groups.
Interesting.
Mm-hmm.
Thank you. Does anybody else have questions or comments?
Oh, yes, we do.
I do. I'll mute myself.
All righty. The dean is going to be asking her question. Dean?
You have to unmute us, right?
So, Liz, that was a fabulous presentation. I enjoyed it very much. From somebody who has worked with PICC line nurses, I find that fascinating. And my question really has to do with your next steps. So what is your plan to disseminate this information to your colleagues, to the nursing community at large, etc.? What plans do you have for yourself?
So the next steps will be, I will go to our site leadership, Deb, and the group that does the look at quality metrics. And I also need to present to our radiologist, system-wide radiology group with the results of this, since they were the ones that signed off on it. So I'll present that data there and hopefully recommend and see what their thoughts are with their group. I don't know. It'll be interesting to hear. You know, it's a cost thing that could potentially have them not have the chest X-ray, but it doesn't. You know, it's not the whole group. It will impact those that have P waves that you could eliminate that, or you don't have to do the chest X-ray. So I will go to that group and see how that works. If that does, then it can spread. And I would hope it would spread to the rest of the other 4 hospitals. So we don't do a chest X-ray after that if you're using the 3CG technology. And then from there, hopefully I can go further.
Well, I would really like to encourage you to take those steps, because I think those are important steps. And I really applaud your collaboration with other professionals. But regardless of what happens with those discussions, this project is very worthy of taking it on to a national level. So I highly encourage you to take this to NTI or another kind of venue, because I think many people will be interested in what you found.
Great.
Yep, you're welcome.
Elizabeth, we have a question from Dr. McGladrey.
Okay.
Dr. McGladrey.
Hey, Liz. So just to piggyback on Jan's commentary about the gender inequality, for my edification, the types of infections that I can imagine needing long-term antibiotics are things like tuberculosis and possibly some of those other infections where you would see it more either in a homeless population, a prison population, that sort of stuff. Is there any indication that the type of infection was more prevalent in males than in females, the type of infections that were being treated?
I would have to look at the data to see what it showed. I didn't specifically break out male versus female, but I can do that. So that's a good.
Oh, I was just curious. You know, just for my own information, I think it's a terrific project, and I am really fascinated by the whole technology. I've been out of the acute care setting for a long time, so it's very exciting.
Yeah.
Yes.
Thank you.
Liz, this is Donna Emanuel, and this really kind of highlights the Dean's comments as well as Dr. Bowler's comments with respect to your cost savings. So for me, you know, it's all about collaboration and interprofessional collaboration across the stakeholder groups that you navigated this project with. And I noticed that, you know, the cost per patient, if you will, was higher in the interventional radiology department than it was using a bedside PICC nurse. Mm-hmm. So I wanted to ask you if you could explore on how the project was initially received in your conversations with those folks, because you had mentioned that you're going to be doing a roundtable follow-up discussion with them to bridge some additional conversations with the elimination of the chest X-ray. Well, you know, without the P wave.
Yes, I definitely will be putting the cost in there and presenting that. That's key, I think, with the group. The nurses in the IR department were excited about having the venous access nurses transition, because then they could do other really longer procedures of what they needed to be doing in IR, and not necessarily the inserting the lines. They'll still insert them, you know.
Sure.
I'll support that, but I would go back with them, and I thought that was interesting too, that it cost a little bit more. but you have to get the transporter and all that.
Sure, sure. I was just looking at that from a perspective because I do understand that, you know, obviously radiology departments in and of themselves who are performing interventional radiology procedures would look at that as you're taking away business from them. And so that's the reason why I was wondering how those conversations were massaged early on to allow this springboard for those educated nurses in, PICC access.
So it's interesting that the radiologist, because it's more of a diagnostic procedure of the read, there was, I think, 2 of the interventional doctors did some reads, but it wasn't, you know, the ones that were reading them, it was really spread all over. There was not one particular one or the other. So it's a doctor other than a diagnostic radiologist reading that x-ray report. But yeah, that's a good point. I'll have to look further into that.
All righty, well, very good. We do have a few additional questions in our chat, so we'll take them one at a time.
I'm not sure if Deborah's still on the call, but
we could share Deborah's comment. She said she had to leave.
Okay.
But she just, she echoed what you've heard from everybody else about how wonderful it was to work with you, and the work that you do is just exemplary. She said the scholarly merits are self-evident. Liz's experience, acumen, and nature make her an exemplary leader, and this was demonstrated by her use of Lewin's change model, particularly in the refreezing stage, as sustaining performance improvement is always a challenge. In addition to the contributions to quality, cost, and patient experience, I highly value the team development and interprofessional collaboration that Liz engendered through this work.
Fabulous. That's a wonderful comment.
Thank you. That's great.
Anybody else? Are there any additional questions? I see 4 from the chat. Just wondering. Okay, that was just Deborah. Okay, very good. Well, with that, Elizabeth, I'd like to say to you, congratulations. I think you did a wonderful job in really demonstrating all of the DNP competency-based outcomes and then some. I think you're off to wonderful new beginnings as you take on your a DNP student scholarly role to that of a doctor of nursing practice. And so with that, I'd like to say congratulations to you, Dr. Elizabeth Morrell. And Jan, I will leave you with final comments along with our dean.
Oh, well, I was just going to ditto to everything. I'm just sitting here going, I can't wait to send this. Way to go, Liz! But I'll just tell you that on here publicly that you're doing a wonderful job. I would encourage you to do some teaching as well, because I think that you just model how to use theory and how to make it work and make it a better outcomes with it and evidence. So anyway, I'll hand it over to Dr. Lopez, but thank you, Liz.
Thank you, Dr. Bowler.
Well, let me be the first to say, Dr. Morrell, congratulations. And you are a shining star, not only for our DNP program here at CGN at Western U, but I think the nursing community at large. And I hope you share yourself with many, many people because they need you. And I hope to see you in some research conference program talking about your project, and maybe even collaborating with a radiologist or a physician of another nature to do an interprofessional collaboration presentation on a national level. So I'm very proud of you, and congratulations.
Thank you.
I suppose now, Liz, it's time for the champagne, right?
Downstairs, ready to go.
I knew it. Well, congratulations. It has been truly a pleasure working with you these past several years, but you are embarking on such a wonderful journey. You're very gifted, very bright, and I could not be more proud of you. So congratulations to you again.
Thank you. Appreciate it.
You're welcome. Do you have any questions for us?
No, it's the journey continues. I know this is just the beginning, so I appreciate all your support and everything with the school. You guys are
Well, wonderful. Well, wonderful. Well, with that, we will officially close our session here today. Thank you so much for sharing your wonderful work with us, and we will be working with you to finish with your final last steps.
Yep. Great. Thanks a lot. Appreciate it.
All righty.